Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers. Today, cancer clusters. What are they and how are they investigated? Suzanne Condon served as Associate Commissioner and Director of Environmental Health at the Massachusetts Department of Health. She and Dr. Megan Latshaw of the Johns Hopkins Bloomberg School of Public Health joined Dr. Josh Sharfstein at a time when cancer rates are rising among young people and questions are growing about what might be responsible. A note for our listeners, Dr. Latshaw is the instructor of an online course on disease clusters that is linked in our show notes. Let's listen.
Suzanne Condon, Megan Latshaw, thank you so much for joining me today on Public Health on Call to talk about cancer clusters. And I'd like to start with you, Dr. Latshaw. Could you just define a cancer cluster for me?
Absolutely. So the traditional definition of a cancer cluster is when you have a greater number of the same type of cancer than you would have expected in a certain place over a certain period of time. I will just throw in there that now people are starting to talk about unusual patterns of cancer instead of the term cancer cluster.
What's an unusual pattern of cancer?
So an unusual pattern of cancer is instead of just saying it has to be a single type of cancer, it's when you group different types of cancer that have similar causes. In other words, if the same chemical causes multiple different types of cancer, you can include them in the calculation.
Great. Now, Associate Commissioner Condon, how did questions of cancer clusters or unusual patterns of cancer present themselves to you when you were leading environmental health efforts in Massachusetts?
Sure. Well, they would come in from a variety of different sources. Sometimes it would be a community person, a parent, for example, with a child with cancer. Other times it might be from a legislator. Oftentimes it was the media. Sometimes it was an academic partner. So there are all different ways that people approach a state health department and ask for help in investigating these types of patterns of cancer.
And was that part of your job to investigate and help people understand whether there really was a cancer cluster?
Yes.
Or whether it was just sort of a random set of occurrences?
Yeah, that was a major part of my job. And frankly, we had pretty good success in Massachusetts in conducting these types of investigations. We can get into it a little bit more later if you like, Josh, but one of the most well-known clusters of cancer in Massachusetts was the childhood leukemia cluster in Woburn, Massachusetts, which essentially came to us as a result of parents talking to their pediatrician, their pediatric oncologist, and saying something's wrong. And the oncologist looking in the waiting room and seeing many people who lived in the same neighborhood that were his patients.
So, Dr. Latshaw, how do you investigate an alleged cancer cluster?
So one of the most basic things that the health department will do is calculate, epidemiologists love our calculations, a standardized incidence ratio, which is basically the number of observed cases divided by what you would have expected to see in the population. And if you're observing more cases than you would expect to see, then that means there might be something going on. And then that triggers another follow-up step.
And how do you calculate that? Does a health department have to go and search for all the cancer cases in that area? Because maybe 3 people show up and say, we're worried this is a cluster or a pattern, but they may not be the only people.
Exactly. Yes. So states have a cancer registry that collects data on cancer. And so a lot of times people will go and take a look at the cancer registry.
So take us back to Woburn, Associate Commissioner Condon. You get a call and there's a question of whether there truly is a problem with cancer that is greater than usual among kids. What did you?
Well, one of the most interesting things about Woburn early on was that we were getting reports from our clinical partners about what they were seeing, which appeared to be an unusually high number of children with leukemia. Unfortunately, there was no state cancer registry at the time.
So you did find a cluster.
Yeah, we found a significant number of children that lived in the northeast section of Woburn. Community members were always focused on the drinking water. The drinking water had been found to be contaminated with some industrial cleaning solvents and such. And it was from that point on that we began to try to determine what was it about these particular children that lived in one particular area primarily, but then cases occurring all over the town that helped us to really pull together this mystery and try to come up with some meaningful conclusions for the community.
So, Dr. Latshaw, you identify a cancer cluster or an unusual pattern by looking at these standardized incidence ratios. You say, wait a second, they're definitely more than you would expect, a lot more. But that's just the beginning of an investigation. What else do you do from that point?
So I think what Suzanne said about what happened in Woburn is you start to look, is there something happening in the community that might be causing excess rates of cancer? And in the Woburn case, it was something in the drinking water that was thought to be causing the cancer. So you think about, what are the exposures in that community? Do they have high radon levels? Do they all live near a hazardous waste site? And you sort of dig a little bit deeper into. And a lot of times the community has theories and maybe even knows what their own exposures are. And so an important part of a cancer cluster investigation is involving the community from the very beginning.
So, Associate Commissioner, I'll go back to you. When you did figure out that there was something going on, maybe something in the water, what happened from there?
Well, there were things that happened early on. So the two wells that were primarily responsible for contaminating the water were taken offline. So the drinking water quality improved significantly. However, exposures had already taken place. And I think one of the interesting pieces about Woburn was that exposure to children after birth did not show an increased risk of developing childhood leukemia. It was exposures to their moms during pregnancy, so in utero exposure, that really was the, quote, smoking gun. When we did trend analyses, we looked at the increasing opportunity for exposure to women during pregnancy and the increasing risk to their child of developing leukemia. And ultimately, we found a significant trend towards increasing risk with increasing exposure. Ultimately, as much as 8 times greater risk for those children whose mothers consume that water or were exposed to the water during pregnancy.
That is very salient, that finding. And how did people react when you were telling them, look, we think we know what's going on?
Right. Well, as Dr. Latshaw mentioned, it's important to work closely with the community. And there's often much emotion associated with these types of studies. One of the most telling things for me when we released the information to the community was having one mother in particular say to me, Suzanne, do you mean to tell me that I was responsible for my child's illness? And I said, no. What I'm telling you is the companies that contaminated your water that you were forced to drink likely played a big role in your child's illness. And so it is hard because I think every parent wants to protect their child.
Wow, it sounds like to do this work from the health department's perspective, you have to be part epidemiologist, part investigator, part policy expert, and also part counselor.
Yes. I mean, there's a certain degree of empathy that is critical when you're working on these types of investigations because particularly childhood illnesses, it's just such an emotional situation.
Dr. Latshaw, we've been reading about allegations of rising cancer rates, particularly among young people, being linked to different environmental exposures. And in some cases, there are concerns about clusters or unusual patterns. I'm sure you read these stories. What do you think is going on?
I think one of the key questions that comes to mind in reading these stories is, what are the cancers that are increased? And do they have similar causes? Because cancer is not a single disease. It is many diseases. that have different mechanisms. And so you really need to understand cancer and how it comes about and all the different causes. I think, the Woburn case is unusual because most cancer clusters don't end up yielding conclusive results. And that can be really difficult for communities to hear. In part, it's because cancer is such a complicated disease. Sometimes cancers can take decades to develop. And so going back and figuring out what these people were exposed to can be very difficult. We don't really monitor our environment that well to be able to reconstruct things. So I just wanted to point out that story is unusual, that a lot of cases were not able to draw conclusions.
On that point, given that many investigations don't turn up a specific answer, do you think it's important for health departments to be able to do these investigations in the first place? Dr. Latshaw?
Absolutely. I mean, imagine how many more children in Woburn and more people in Woburn would have been poisoned and had early deaths if Suzanne was not able to do that investigation. And I think as our tools get better, I have a lot of hope that we can even train AI to help us detect unusual patterns of cancer before people in a doctor's office have to say, I would like to be able to try to catch these earlier. So health departments need to be doing these investigations, even if we don't always find the results. When we do find the results, they lead to interventions that save lives.
I wonder, Associate Commissioner, if you could talk to me about what it's like to tell a community that we couldn't find an answer.
I think this is where the importance of community engagement comes into play. I did spend a lot of time working closely with communities, legislators, just the general public on these investigations, because the point here is to try to let people know that you've looked at the tools that are available to you. You've taken an honest look. And sometimes you're not able to make those connections. And sometimes statistical fluctuations can occur by chance, particularly in a smaller community setting. But the other thing that I think is important to sort of keep in perspective is through those cancer registries that are critical to this work, trying to monitor going forward to see if the pattern does change. And I guess the other thing I would say is if you don't look at something, you'll never find a problem. And so I do think this is a critical activity for state health departments. They have the data. It's important to share the data with the public and let people know what the disease burden looks like and be able to put cancer in perspective.
And Dr. Latshaw, are you worried that with cuts in public health funding that it'll be harder for health departments to do the kind of investigations that the Associate Commissioner here told us took up a lot of her time?
This takes money, resources. It takes a lot of people power, epidemiologists and toxicologists and environmental scientists, and so many different people are key. And so I think if you don't have those people or the resources needed, we're going to be missing things like this and not able to investigate.
Suzanne Condon, what would it have been like to tell people that you just didn't have the resources to do one of these investigations?
Well, what's interesting is I did have those challenges historically. And I think one of the most important things I learned was in a study we did of young men with rare sarcomas, angiosarcomas in the community of Ashland, Massachusetts, where I went to the community and I said, it looks like the numbers are high, but the kind of study that we would need to do would basically require us to go back and identify people who lived here decades ago, people who went to the high school where all these young men had gone and been diagnosed with these cancers. And a woman stood up in the back of the room and she said, Suzanne, that won't be a problem here. And I said, excuse me? And she said, we know where every student that went to school here lives. We keep track of those things. And we also had a person in the room that was from the local senator's office who basically committed to finding the resources to pay for that study. And at the end of the day, we did see a connection between opportunities for exposure to a particular hazardous waste site, particularly water exposures, and the higher rates of rare cancers, and particularly those sarcomas in that community.
Sounds like that was really a community-driven resource.
Absolutely.
For you at that time. And it would really be a shame if that kind of opportunity were lost.
Absolutely. Yeah, it is really critical. And I think that's why I couldn't stress enough, as Dr. Latshaw did, the importance of community engagement and involvement of all the players, including academic partners. I'd be remiss if I didn't say that it was one of our academic partners that helped us with the statistical trend analyses way back when we were doing Woburn. So I think having these partnerships in place is critical to the success of this work.
Well, Suzanne Condon, Megan Latshaw, thank you so much for joining me. I've learned an awful lot about both cancer clusters and unusual patterns of cancer.
Thank you so much.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.